Yeah.
There you go. You're good to go.
All right. Ice cream boys.
It's hard to get a bunch of moments.
We'll start here in a second. This recording is just going to watch me eat my almonds here. I didn't have breakfast this morning. And the reason I was late is because I was at a orthopedic office with my son, getting his cast on.
Broke his arm or something?
Yeah, I broke his hand. I don't think Alec was here.
I saw part of the story in the recording thing, but you just cut that off yourself.
I don't know. Doug probably does that. Cuts out what he doesn't want you guys to hear or other people to hear. Bleeps out my bad language. Oh, I don't have very bad language, right?
Right. I think I was an idiot.
So is there something that's cast off, or
What's that?
is there something that's cast off? Or
No, he was getting a cast on.
Cast off.
We'd splinted him and now he's got cast.
How did he break it?
Sledding. I know, right? But he did it because of his pride. He ran into a bunch of kids. And then thinking that he was going to show them, but he's such a little dude that it's like running into a brick wall. But he's 9, but he's just bones. He's so skinny. But we didn't want to, or I didn't want to take him in earlier because we were skiing for that weekend. So we let him ski for a couple of days with a broken hand before we took him in.
Is he a pretty good skier?
Yeah, he's a pretty good skier.
My son at home, he was like 3, and this year he's really starting to pick up on. Take him on. The better runs.
Right. You can actually ski. Yeah, it varies between my 3 boys. All right. You guys got the right lecture brought up or with your guys' stuff? Ventricles. So these are the least efficient pacemaker, right? We talked about this, 20 to 40 heartbeats. So it assumes responsibility if the SA node fails. Impulse from the SA node is blocked. The rate of discharge from the SA node sucks. Or there's an irritable site in the ventricles, just like excited or irritable sites in the atria can cause impulses, right? So those ventricular beats can originate from any part of the ventricles. So the QRS is abnormal and prolonged with impulses that come from the ventricles. Because then it's going through a different conduction system and you get this delayed looking QRS wide, right? So that makes repolarization also abnormal, and you get changes in the ST segments and the T waves. So the T waves in these situations, when you've got excited cells beating in the ventricles, the T waves are generally, the deflection is opposite the main deflection of the QRS. So if most of the QRS is deflected negatively, the T wave will then be positive. If most of the QRS is deflected positively, the T wave is going to be negative. Okay? That is also called discordance. So if you guys wanted to make a note, if you've got the slides right under that second bullet point where it says T waves are usually in a direction opposite of the QRS complex, that is termed discordance. That will become important when recognizing if there is a heart attack on top of a pace rhythm or bundle branch block that already will have an ST elevation. So PVCs, in contrast to PACs or PJCs.
So backing up, the QRS is mostly negative, the T is going to be negative too.
No, if the QRS is mostly negative, then the T wave is going to be opposite. It's going to be positive.
That's for normal sinus.
And that's called discordance. No, that's not normal sinus. That's what happens with ventricular depolarization. Meaning if there is a wide abnormal QRS, normally your T wave is going to be in the opposite direction. All right? All right. So, how do you recognize a PVC? So it's from excited cells or irritable cells, other than the normal conduction system. It occurs earlier than the next expected beat, just like a PAC or PJC. You'll see it kind of beat right after another QRS out of the normal pattern. That QRS complex is going to be wide, and the T wave is going to be in the opposite direction as the QRS for a PVC. All right? So what is the first premature beat? The first strip. What kind of premature contraction is that? PAC. What's the second? PJC. What's the third? A PVC. Does everybody understand the difference? And how you can tell them apart?
For Trevor's sake.
So the top strip is a PACY. So you know that it's a premature contraction because it's where? It's out of the rhythm, right? So you've got normal, boom, boom, and then you've got a quick beat with a different looking P wave. You still have positive deflection. That is what? That's a PAC as well. So that's a premature atrial contraction. You know it's atrial contraction because you've got upbeat P wave with a normal, otherwise normal QRS. QRS still looks about the same, right? This strip, you got boom, boom, boom. You might look at that strip from a little bit further back and go, oh, that's an irregular heart rate. But it's not an irregular heart rate, right? That's a regular heart rate with intermittent PJC, right? That has a negative deflection.
So that's a PJC. That makes sense, right? The junctional rhythm comes from where?
The junction is the bundle.
Comes from the AV node, right? So it's going out from the node to the atria. So you've got an opposite deflection in the electrical impulse, and you get a negative inverted P wave. That's a PJC.
Number 6.
Number 6 is a little bit harder to tell because it's buried, but you would assume that it's a PJC because you already have PJCs. But it's flat, you don't have positive, you don't have negative, and sometimes the electrical system is not picking up those minute changes. If it was a super sensitive EKG on an optimal person, you might see the deflection. But for whatever reason, you're not seeing the deflection.
Consider number 6 with PJC just because it's narrow. E-wave's probably buried somewhere. Even if you didn't have
Right.
number 4 on there. It was one.
True, you could assume, you might assume that it's a PAC. If you didn't have this, you might think that it could be a PAC too. So PAC can have positive deflection. It's an abnormal looking P wave from the rest of them, but sometimes that P wave can be really flattened, right? And you might not even see it. So that one's a little bit iffy.
Are you getting PJCs and PACs in the same rhythm? But like, let's just say that
Like in the same strip?
You say, yeah.
Yeah, you could.
I didn't know it was like one.
If the patient has, excitable sites, and yeah, you could. This third strip, you've got normal, boom, 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 and then you've got a premature contraction. It's beating before the next assumed beat, right? And there's no P wave. So right off the bat, no P wave, you're thinking, oh, that's probably further down on the conduction system. Now, it could be that P wave is just gone, and if the normal QRS, then that's still higher in the conduction system, PAC or PJC. But you know it's a PVC because what? Super wide.
So that little hump at the end of the PVC, is that the repolarization? That's why it's just a lot longer.
The hump at the end of this,
Yeah, that guy.
that's a T wave. Yeah, that's repolarization.
So since it's just a really long, crappy rhythm, it's just following it all back with it.
Right, repolarization sucks too. And where's most of the deflection in this QRS?
Negative.
Negative. So where's the T wave? Positive. And that's what I'm talking about when that becomes important later, not necessarily for this test, but later. And that's discordance. If you have concordance and that beat is concordant, then you have the T wave in the same direction as the main portion of the QRS. And that is pathologic
So piggybacking off
for ischemia. What's up?
you'll have concordance on normal sinus rhythm.
Not a normal sinus rhythm. Well, you'll have concordance on normal sinus rhythm, yes.
Okay.
If you have concordance on a wide complex QRS that's not an AV block, meaning it's ventricular, then that's bad. Okay? That's part of Scarbosa criteria. We'll talk about that later. Eventually, you guys will need to know that, but not for this test. All right. So how do you recognize PVC? You get that full compensatory pause that follows the PVC. So this is semantics. This is full compensatory and incomplete compensatory, which is also called non-compensatory or whatever. But you guys see where the difference is. Full compensatory means that, so this is showing a sinus cycle, meaning that P wave, P wave, P wave. This is where the next beat should be, and the PVC hits before it. The non-compensatory cycle is that, but in the compensatory, the next beat after the PVC is still in the normal position where it should be, okay? That's compensatory. Non-compensatory means that the next beat where it should be is out of alignment. When that SA node resets and does its thing, it's not in that same alignment, or it's not in that regular beat of where it should be. All right. Fusion beats is when you have a supraventricular impulse at the same time as a ventricular impulse, meaning an ectopic site in the ventricle. And so you get this fusion type complex of the two firing at the same time. They don't resemble normal beats. It's the fusion complex really is difficult to differentiate between a PVC or a fusion complex. Just know the definition, not necessarily how to recognize it, because it's difficult to recognize it. All right. So PVC patterns, you got a pair or a couple where it's two sequential PVCs. A run or a burst is 3 or more. Bigeminy is every other beat is a PVC. Trigeminy, every third beat is a PVC. Quadrigeminal, every fourth beat is a PVC. Sometimes they can be in kind of a regular pattern. Uniform PVCs, meaning all those PVCs look like each other, right?
PVCs perfuse.
What do you think?
Yes.
Yeah. QRS contraction, right? It's not as good. You don't have the filling because it's premature, right? But it's still contracting and pushing blood out.
Back to your flushing blood there. Flushing it too soon.
What a great analogy. Good job, Layman.
That's mechanical, not electrical.
All right. Multiform PVCs, these are PVCs that look different from each other. Why would you have multiform PVCs? All right. There's more than one excitation site firing that premature complex. So you're going to have different looking PVCs. But as you'll notice, in each of those PVCs, you've got two that are uniform and then you've got one that's different, right? But you still have T-wave deflection opposite of the main QRS deflection. Interpolated PVCs do not have the full compensatory pause, which means that the next beat is not where it necessarily should be. It's squeezed between two regular complexes without disturbing the underlying rhythm.
As for the last, where do you, like on this one, where would the G point be on that odd?
But for normal circumstances, you had a run of PVCs, and that became the rhythm. And you had that J point that was down there. Would you be able to call that ST elevation, ST depression significant?
Oh, with this good here.
Meaning would this one be? So say you had a whole strip or a run. You had a run or a burst of PVCs. So you got this ST depression, right?
Yeah.
Is that significant? Does that mean MI? Or is that just something that happens with PVC? Right, it just happens with the PVC. Now, in this case, does this person have a problem?
Yeah.
Yeah. His normal PQRS segment has what? Pretty elevated ST.
That's like the tombstone.
Yep. Well, this patient is having an MI. All right. So the R on T PVCs. So that happens when the R wave falls on the T wave of the preceding beat, meaning it's just super fast. So that's the relative refractory period of that T wave, right? Where it's repolarized enough that a PVC can cause a contraction. When this happens, when it beats right at the end of that T wave or on that T wave, now this doesn't always happen, but it can turn into VTAC or VFib because it can just reset the conduction system, and then you've got a whole mess of problem. So we talked about the two pairs, and then we talked about 3 or more PVCs as a run or a burst of VTAC. All right. So a pair is just a pair of PVCs. If you've got 3 or more, that's a run of VTAC. If the heart rate, if that burst is more than 100 beats per minute. So if you're reading a strip and you're trying to, call in and explain it, like, we've got normal sinus rhythm with a 6-second burst of VTAC. And then spontaneously back. So PVCs are usually within normal limits. They're usually not a problem unless they become more frequent. PVCs, P waves absent. Sometimes the P wave can be buried in the QRS, hard to recognize, but if there's a reentry pathway or something like that, and that conduction of the ventricles from the excited state somehow gets to the atria, then you can have a delayed contraction of the atria and have a P wave buried in the QRS.
Do people normally throw PVCs just in everyday life?
Yep. So it can occur in healthy persons with apparently normal hearts and no real reason for them. The incidence increases with age. We see them a lot more often in the elderly. What causes it? Like I said, it can be normal, hypoxia, stress, exercise, ischemia, electrolyte imbalance, all of the above. Medications, anything that would increase your sympathetic drive, your TCA, antidepressants can certainly cause them. Patient's symptoms, they complain of flip-flops, palpitations, racing heart, skipped beats. They'll say a whole bunch of different stuff. Sometimes it can cause chest pain or neck pain, feel like a heart attack. So treatment is obviously dependent on the cause and how the patient's looking. Escape beats. We talked about atrial escape beats, right? Now ventricular escape beats. So it occurs after a pause when the supraventricular pacemaker, SA node or the AV node, fails to fire.
So the QRS is generally right on the border to wide. It's late in the cardiac cycle. Ventricular escape beat is different than an atrial escape beat in that it's later in that cycle, meaning later in that arrest. And in the same regard, it protects the heart from asystole, from extreme bradycardia, etc. So there's an example of ventricular escape beat. Normally, if you have an atrial escape beat, you'll have a P wave and it'll occur earlier in that arrest, right? Boom, and then you'll have this long arrest before it resets. But the ventricular escape beat will be later, there's no P wave. You still have a wide QRS. So why is that not? Because it looks like a PVC, right? Why is it an escape beat and not a PVC? Right. PVC is going to be right after, right? It's premature contraction. It's going to be before where you would expect the next beat. Escape beat is going to be after where you would expect. The SA node didn't fire, and so the escape beat fires.
Does that fire from anywhere along the Purkinje's, or is it just at the junction? Or is it, no, I guess it'd be anywhere, it would be anywhere along the Purkinje's, right?
Yeah, the escape beat can be, can come from, from the his down. Really anywhere. So sometimes you'll see this normally. You'll have a regular looking rhythm, and then you'll have a late beat. And that's an escape beat. It'll be wider. No P wave, or at least you won't be able to see a P wave. There's no PRA interval. The QRS is often funky looking. All right, escape rhythm. This is also called most of the time you'll hear this from the docs, from the hospitals, from your medics that you're working with. They'll call it an idioventricular rhythm rather than a ventricular escape rhythm. More commonly called an idioventricular rhythm. So this is 3 or more escape beats. It's an agonal rhythm, meaning that the heart's not beating, so it'll throw this run of escape beats, and it's called an idioventricular rhythm, but it'll be very slow. So you kind of see that when a patient's, when they say, oh, the patient's bradying down, that's usually because their SA node, AV node has given out, and the escape beats kick in, and it's this idioventricular rhythm, and it's super slow. And that's right before, and you don't feel a pulse. Those idioventricular rhythms, if you really paid attention and waited, you probably would. But usually, you'll see your medics or you guys will put your finger on their radial pulse on the carotid, and you'll wait like 5 or 10 seconds. I don't feel a pulse. Well, it's slower than that. You might if you sat there and waited, but it's a stressful situation. You're like, I don't feel a pulse. Start CPR, right? And then you'll look up at the monitor and you'll see this slow rate, and you'll call it a what? You'll call it a PEA, because you won't feel a pulse. Now, if you really paid attention and you could feel a pulse, then you'd be like, oh well, they're having a pulse. It's just too slow. And should you be doing CPR anyway? Yeah. So either way, you should be doing CPR. It depends. If you've got significant cardiac injury where you've got dead cells and dead tissue, and that's what's causing this idioventricular rhythm to take over, you still might not feel a pulse because there's too much dead tissue to cause a contraction, or enough of a contraction to pump blood, right? So you could try pacing, but depending on how much injury there is to the heart, it might not work. Now, if it's just injury to the conduction system and the heart muscle is still salvageable, then pacing will work.
So I hate to play the what-if game, but if we were driving around, we have a really short downtime, and so we said, oh, it's collapsed, we're able to get the monitor on quick enough to see that, you go down the line of pacing before going full blown. Crew CPR and everybody pumping shots.
That's a little bit of a hard one. I probably wouldn't. I'd probably just start CPR.
Okay.
Because getting the pacing all set up takes a little bit of time. You could certainly try in a pause where you're identifying a rhythm, try turning on the pacer. You know, if you've got what looks like an idioventricular rhythm or whatever looks like a PEA, you could try pacing them, but there's so many different things that cause PEA that pacing the patient won't help. So really, you should be doing CPR, and then you can figure out if they need to be paced later.
If it is IVR, then pacing help.
Like I was telling him, it might not. Depends on how much cardiac muscle is dead or not. Because right, PEA is when you have conduction, you've got electrical activity on your monitor, but it's not, that electrical activity is not creating blood pressure, right? It's not creating a palpable pulse. That's what PEA is. Now the heart could still be trying to contract, the conduction system's still firing, but there's too much dead tissue or there's other factors that's causing not enough blood flow to actually go, so that when the heart contracts or tries to contract, you're not getting enough blood flow, you can't feel the pulse, you don't have a blood pressure.
Okay, then. So you've gone to the CPR, you got you start to break that down, you then go to pacing. See if you can that.
Yeah, you could certainly try pacing if they're starting to Brady back down, or stick them on levofed or dopamine, because likely what, you know, your CPR is the most important, right? That is more important than anything else that you do is correct CPR. With good recoil, good pressure, the whole bit. But also, you'll notice when you have codes like that, they come back with the epi for short periods of time, then they Brady down and you lose them again. Then they come back when you give another dose of epi. Their heart is needing that help, and so you want to start a drip to get them really going. Because they're beating on their own. It's just that they're either as a conduction problem where they're not getting enough, and just the excitation of those neurotransmitters are helping increase the rate temporarily. So, you know, the medication oftentimes in those situations is going to be more effective than the pacer. Because for whatever reason, the conduction system's working, it's just not creating blood flow, right? So pacing them in an already working conduction system's not necessarily going to help you. All right. So this is idioventricular rhythm. Like I said, slow, 20 to 40, essentially regular. P waves are absent. They might be hidden in the QRS somewhere. Again, the QRS is opposite the T wave deflection. No PRI interval, got a wide QRS. And this is just a repeat of that same material. So IVR, when does it occur? So the SA node and AV junction fail. They're not stimulating an electrical impulse, or the rate of the SA node and the AV node sucks. Now, it'd have to really, really suck for an idioventricular rhythm to take over. But certainly can happen. Or the impulses from the supraventricular pacemaker is just blocked. So it can be because of an MI, DIG, metabolic
abnormalities, hyperkalemia, magnesium. So the atrioventricular rhythm, because the atria is not contracting or might be contracting at the same time as the ventricle, you don't get that atrial kick. So you have a decreased cardiac output with these. So not only is it slow, but it's also not a great contraction. So if you can catch that idioventricular rhythm and you don't necessarily, like if they're sitting around 40, 30s, 40, and they're kind of somewhat awake and holding a blood pressure, even though it's not great, you can try pacing, right? But if they completely tank, you're probably going to want to do CPR. So PEA. So this is not a dysrhythmia. This is a problem with the actual contraction, right? The blood flow of the heart. So this is when you have organized electrical activity, like we talked about, but there's no pulse. There's no output, at least strong enough output for you to detect, right? Causes of PEA, pulmonary embolism, acidosis, tension pneumo, tamponade. These are when you're going through your H's and T's, right? A lot of these are H's and T's, hypovolemia, hypoxia. Do you guys understand why all of these can cause PEA? Why is a PE, why is pulmonary embolism going to cause PEA? It's not an original problem with the heart, right? Conduction system's still working just fine, but there's no preload because that PEA causes backup, or that pulmonary embolism causes backup, and you get no preload, you get no blood flow. Heart's sitting there trying to contract, but nothing's going. So it's a PEA. And you'll see that frequently with codes, and you're like, well, is this a PE? Do we need to transport quick so this patient can get lysis of that clot? Tension pneumo, cardiac tamponade, same regard, right? Decrease in preload. All right. Let's see. So treatment in PEA, unresponsive, apneic, pulseless. Prognosis is usually not great unless you can treat quickly, right? They've got a tamponade. You can stick a needle in it, do a little pericardiocentesis, get the fluid out. If you got a tension pneumothorax, you can stab the chest with a 14 gauge and relieve that pressure, and you can resolve the PEA real quick, right? So CPR, oxygen, tracheal intubation, really try to find the cause. If you got a PEA, you know you got good conduction. You want to try to figure out the cause so that you can fix the problem and get blood flow back. Now, if the cause is PE, all you can do is transport quick. If the cause is MI, then again, all you can do is transport quick, right? Not a lot you can do in the bus. All right, an accelerated idioventricular rhythm. Oh, there's my adolescent, pubescent voice cracking. All right, so how do you recognize this? It's accelerated, right? So if you've got a normal idioventricular rhythm, that Purkinje system is slow, 20 to 40. If it's more than 40, then that's an accelerated IVR. Regular, it's just faster. Everything else is basically the same. P waves aren't there. They might be hidden in the QRS. You got a regular rate, but it's faster in the 40s to 100s. No PR interval. The QRS is wide. Again, the T wave is opposite the QRS complex. So can be considered a benign escape rhythm. It's there when the sinus rate is slow, and it disappears when the sinus rate speeds up. seen with ischemia, of course, MI, and you'll see it post-MI after they've been reperfused. Patients their heart is doing all sorts of wacky stuff. They'll have runs of PVCs, they'll have runs of IVR, it'll do all sorts of stuff when it's being reperfused. So all these things cause it. Cocaine, that's a lovely one. Yep, DIG toxicity, which causes all this stuff. So treatment with AIVR, you don't always need to treat it. It's a run. They're being perfused because their heart rate is normal. If the patient is symptomatic because their overall cardiac output is low because they're not getting that atrial kick, then you can certainly treat. Now, it's a little bit of a against logic to give the patient atropine if he's beating at 80-something beats per minute, right? But if you can recognize that as an accelerated IVR, where is the problem with the IVR? Or why is the patient in IVR? Where's the problem? Where's that beat coming from, I should say? Let's start there. It's coming from the ventricle, right? And so there's probably a block somewhere. The beats come, or the SA node or AV node just is sucking for whatever reason, and so that ventricle takes over and you get this accelerated IVR. If you give atropine, where does that affect the heart? Does it affect the ventricle at all? So it's not going to make that AIVR faster. It's not going to do a thing to the ARVR, right? Because those sympathetic connections aren't at the ventricle. So it's not going to affect the AIVR. It's not going to make that heart rate faster. What's it going to do? It's going to try to speed up the SA node. And if the SA node can speed up fast enough, it can take over again. And then you'll get normal PQRS with an atrial kick. That SA node can take over again. So atropine in this instance would still be effective because of the way it works. And you could certainly try atrial pacing, which would need to be done transvenous.
How would you know it's not like a third-degree block or something where you're just not seeing P waves?
Third-degree block, you would still see P waves, right?
Yeah.
And a third-degree block would be, well, most of the time would be slow, but if it's a higher third degree, it can certainly be faster than 40, but you're going to see P waves marching out. That is like the telltale sign of a third-degree AV block is you see marching P waves that are independent of the pulse of the QRS.
Atrial pacing, you have the big long catheter and poke the atrium.
Yep.
Shock it.
It's transvenous. Can't do that transcutaneous. The atrial pacing.
You gave atropine, is there a chance of resetting or get the SA node back online and you get back to the rhythm under the initial 80 rhythm?
Usually no, the SA node to take over needs to kind of get above that. Now, with atrial pacing, I mean, you could increase it until you get capture, and then lower the heart rate, depending on what the patient's needing. But usually, the atropine works to get the SA node firing above what the ARVR is in order to take over. So VTAC. All right, let's see. Let's take a quick break because this is when stuff starts to get more important. Take a quick break, stretch, do whatever you need to do. You got like 2 minutes.
I need another handful of almonds.
That's right. I pick out all the M&Ms, so if anybody wants M&Ms.
I would take them, but I ate as advice. I don't think I need the calories. So. Peanut M&M.
No, they're regular. You want them?
Is that one of those Costco?
Yeah, it's that Kirkland thing.
What is this? Yeah.
Oh, help.
Okay, because you don't know what lead you're looking at, so when we go, our lead selection lines can help our way progression. Now, so, you know, like B1, B2, your QRS complex should be fairly negative, right? Because the way that looking at the heart, right? Because all positive, all these things, all there is positive electricity either going towards positive electron or going away from the positive electron. Positively looking at B2. Think about the way the heart is, right? Think about the way B2 looks. Is this way. And you think about generally positive. It's more, that's sort of